So, good afternoon, everyone from India, and thank you so much for joining. We welcome Professor Maha Al Tantawi. Thank you, Maha, for this accepting for this lecture series. Basically, we've started this initiative just for the postgraduates and young faculties of dental public health in India, and this time we have tried to take it to Southeast Asia too. So, to actually understand what is happening globally in dental public health, and we welcome you for today's lecture. For others, just to brief that Professor Maha Al Tantawi has done her BDS, MSc, PhD. She is a professor of dental public health in Department of Pediatric Dentistry and Dental Public Health, Faculty of Dentistry, Alexandria University. Madam has an H index of 52. She has over 25,000 citations. She's been involved in around 400, more than 400 research papers. So, a very academically stimulating profile, ma'am, and thank you so much. So, over to you. And thank you for all the participants who've come here, and it's all because of the participation that helps us or motivates us to keep this lecture series on. Uh, not the least, the people who've always backed up. I must thank them also. Dr. M. Srinivas, Director, AIIMS, New Delhi, who's a source of inspiration in all the endeavors which we take up, and Chief CDR, Dr. Ritu Dugal, who has been encouraging us to take up such topics and bring global relevance to our Indian students and faculty. Thank you so much, everyone. Over to you, Maha. Thank you.
Good morning or good afternoon. Thank you very much for the invitation. I'm very privileged to have received this invitation and very glad actually to join all of you. And thank you also, Harsh, for the kind introduction. It's very nice. So today, I think it would be nice to talk a bit about the dental public health and technology. Dental public health is my specialty, and technology is my passion. And I assume that maybe many of the attendees would agree that dental public health or oral public health at the present time is of great relevance to address the many global oral health challenges. Without technology also, it would be difficult or almost impossible to do so. So for framework and to shape the discussion that we're going to have today, I'm using this document. This is the Mobile Technologies for Oral Health, an implementation guide, a manual that was released by the WHO in 2021. This is a nice document because it helps arranges the many innovations in the area of mobile technologies, digital technologies, electronic interventions that people are using for to support oral health. And basically what the document, how it structures the oral health interventions is along these four domains. The use of oral health, and oral health is just like a subset of the digital technologies, but it may also help us arrange our thoughts. So oral health interventions for training of healthcare professionals, in this case dentists and oral healthcare professionals in general, training and education. And then there is literacy, which in some settings may be known as dental health education. This is to to improve the knowledge, attitude, and practices consequently of different target groups, whether they are adults, children, mothers, workers, and so on. And then there are the oral health or digital interventions for the early detection of oral diseases, and I'm using the term like it was used in the manual with early. Even though not all the interventions specifically target the early stages of oral diseases. And oral health surveillance. And I would say that the sequence of the different domains may reflect whether the literature that there is about them or the amount of interest in them or what has already been done in these areas. If we're going to talk about the technology, let's keep in mind one of the many important tools in this respect, the internet. Okay, and I was trying to find like a more recent timeline. I couldn't. Like you can see, it stops around the 2020s, which is the case. However, it misses. It sort of like misses what happened after 2020. So skipping to the 2000s, this was the time before the 2000s. It was the time of the .com boom, which are basically websites spreading all over the internet and giving information or disseminating knowledge. This is whether it is related to healthcare or any other field. Then with the starting the 2000s, there was the broadnet, mobile internet. And then very interestingly, from 2000 to 2010, the social media, Web 2.0, 2.1 is, or 1.0, sorry, Web 1.0 is or the
login. Hey, whoever is free, log into that.
I would request...
Are the websites. 2.0 are the 2.0, what 2.0 is the age of social media. And this is very much different from 1.0 because it was like going both ways. It was interactive. It allowed websites sort of like, or people developing the content to tell the public something and the public to respond back, which was major change. And then starting from 2010s, the inter-cloud computing, streaming services with the pervasive use of videos and like very heavy files that can be uploaded into the internet and viewed with ease. The reason I'm saying that it's sort of like stopped by 2020 because it only said or told about the 5G and the Internet of Things. I bet that by the time that this figure was developed, AI was not in the same condition that it is now. Else, otherwise, it would have definitely featured on the timeline. Back to the WHO framework, and this is like way back in the sort of like the dark ages of the use of technology for oral or dental public health. Like you probably remember, we're going to use the WHO framework, which starts with training and education. This is an early paper. This is in 2008, where people were just debating whether students will accept the use of computers in education or whether it is like a new thing that will soon be dropped and we do not need to think about it. This is one of my papers, and as you may expect, students were more accepting of the of computers in education. Not all students had computers, of course, and in that time, like would expect, there were no laptops or they were not as widespread as they are now. So this early perspective, like it is how many, like 16 years ago, just 16 years ago or something, tells you how the developments, how the pace of the development in this area is huge. A bit forward in 2014, this is another paper in the Journal of Dental Education, and now this at that time the Journal of Dental Education had this. I'm not sure if they still do had this kind of publication. I think it was called Point Counterpoint, where there were two viewpoints presented in sort of like a commentary. In this case, there was a commentary or a viewpoint that laptops would be good to use in the classroom, and in the other that they were not that good. So instead of like 6 years before this paper talking about computers, now this paper talks about laptops. And the topic may be still on. This is 2011, and now this paper is about e-learning. And if you can read the second line, the font is rather small, but they're talking about an e-course given in a DVD format. I assume that now most people would think this is rather unusual. Many people do not even have a DVD slot in their laptops or computers, but this was very common. Like I had this course, or an educator had this course, and instead of writing the course resources on paper and giving them physically to the learners to use, they would put everything on a DVD and share the DVD for students to have copies from. Alternatively, if you're thinking of training, not education context, suppose that a Ministry of Health somewhere had this new modality of treatment or this kind of intervention or clinical practice guidelines that they would like dentists to use in the public health clinics or something. They will also include the material with maybe like images and training questions in a DVD and disseminate to the dentist to use also as a resource, as a learning resource. Of course, the problem with that was it was difficult to update. There was this problem with DVDs. It opens now, it doesn't open now, and once you disseminate it, you have no control over it because people may share and copy on another thing and add and remove from the content. So it was rather difficult to keep track of the quality of the content on these physical resources. Then, if you remember the timeline of the development or the evolution of the internet, enter Web 2.0, the interactive part or stage of the internet, the beginning of the interactive stage of the internet. On the left is a paper about blogging in a biostatistics and research design graduate dental course. This is also one of my studies. And at that time, what were the challenges? Well, there were a largish, I would say, number of postgraduate students taking a basic course in Biostat, which is dental public health education. And the Alexandria University at that time, my institution did not have an online platform, an online or a learning management platform like it does now. So there was this problem that there was a large number of students who needed to have access to course resources, and there was no electronic platform. And like developing a website for the course was not logic because there were no financial support for this, and because it will need to be updated like from year to year, course offering to course offering. So what was the solution in this case? A blog. These were very popular at that time, blogs and wikis and all these Web 2.0 tools. And on I was like, when I was preparing the presentation, I thought, well, is it still alive? Is the blog of the course, which was created like 15 years ago, still alive? And it was. This is what you can see on the right side, the blog of the course. This is the course code, Biostat 08671, and you can see some of the items or the things posted. And on the left, there were labels to help students directly access the content that they needed. So Web 2.0, it was quite handy. It had very good acceptability from the students because it allowed them for the first time to interact, to ask questions. Even there was this kind of like a gamification where I post like questions or quizzes, and sort of have a deadline by which they can answer, and the first to answer correctly was acknowledged on the blog and stuff like this. So Web 2.0. The blog allowed sort of like text interaction, like they would say something and I would respond back. They also could discuss by themselves. Now, what we can see here is a Move. Move is a multi-user virtual environment. Multi-user virtual environments are still used to this time. At that time, again, this is 2013, they were very popular, and this is Second Life. I'm not sure if any of you is familiar with it. And the screenshot on the right is today's. So this is how the landing page looks. What is a Move? What is a multi-user virtual environment? It is this platform where you create a persona, like an identity. You create, of course, an account, a username, password, and when you enter the Second Life, you're asked to create a persona or an avatar. They call it an avatar. How it dresses, the skin color, the name, things like that. And the name keeps like hovering over the head of the avatar wherever it moves. The avatar can move, can talk, can teleport. So, like for example, in Second Life, there are this island for the, for example, Alexandria University, and then this island for the Old Institute Medicine of India, or any other institutions or country or other organizations. And I'm here in Alexandria University, and I want to teleport to, for example, Brussels to attend a conference, and I can do this, provided, of course, these entities have created a virtual presence on Second Life, on the Move, on the multi-user virtual environment. And other avatars also can interact. You can see their names, like their full names, like, for example, me and Harsh can interact inside the virtual environment Second Life if we both have avatars, and it creates a really real feeling. You can feel that like you are talking with real people, and you even mind the direction and like not bumping into someone. I remember when I was trying to learn how to use the controls and turn right and left, and then I turned right sharply and bumped into someone, and I had to say, so it's really it feels real. We use this in teaching. Part of the again dental public health course. This time to undergraduate students. It was about fluorides, names of fluorides, systemic fluoride, topical fluoride, things like this. And this was like a real experimental study with a control arm. These were students who were not exposed to the Second Life, and a test arm where they were, and there was a before-after measurement of knowledge and practices, how they improved in the way that they inserted a fluoride gel tray and set up the patient and told them the instructions and stuff like this. And it was really nice. What's the the point, or what's the sort of like things to watch with things like Web 2.0 tools, like the blog and the Second Life. They are very time consuming. They create like a parallel life that educators need to tend to. So I have to prepare my class, I have to do my research, I have to attend the meetings of the committees, and then I have to tend to the structure of the blog and respond to the comments or questions, and the same or even more so for the for Second Life. Second Life especially has a learning curve because you can also build the virtual environment of your organization. You can do it yourself, but it takes time to know things. And there are like these tokens that you can get if you do if you win contests and things like that. These tokens can help you get readily made parts of the building, for example, or the furniture, or the or things to do for the virtual presence of your organization. For training also, this is the social media age. This is 2015, and social media, like whether it is academic social media sites like ResearchGate, like LinkedIn, like this, or non-academic social media which people can use for education and training, like anything almost, like Facebook, like Instagram, like Twitter or X. And social media have like people prefer different kinds of social media in different countries, and different age groups also do. So if you are thinking of using social media, which are still very relevant in education, you need to be aware of which type of social media your learners are interested in. For example, if now here in Egypt, if I plan to use social media for undergraduate students, I would use Instagram maybe. However, I'm reaching out to dentists in the Ministry of Health, I will use definitely Facebook. So different in age, different by country. And they are very, I would say they are very handy. You just need to create an account. It is very, I would say, like commendable, or it is expected that organizations would have social media accounts. Like this is the Facebook page of Alexandria University Faculty of Dentistry, and or actually Alexandria University, the main university. And this is the Twitter account of like Sheffield School of Dentistry or whatever. So accounts for the organization, and they can also be used for training, like to announce things like this, like the dissemination of the poster for this current webinar or meeting. It had to be, I assume, posted on social media to know about it. There are considerations which people need to be aware of, like and students need to be introduced to, like sharing patients' information on the social media, de-identifying like photos or images or radiographs and things like that. So the ethical consideration and ramifications of using social media in dental education and training are important. Instant messaging in dental education, and this is very important, and it is, like, I would say, the paper is in 2015, but it is still relevant. And there are many, of course, platforms that people can use for instant messaging, and the thing keeps transforming, like it has a life of its own. Okay. Like from 2012 to 2019, I was in Saudi Arabia, and WhatsApp was there. I mean, like people were using WhatsApp in different countries, and the use of WhatsApp was like for strictly instant messaging. Like I would be a bit late, like 1 or 2 minutes from class, and I would WhatsApp the class leader that stay put, I'm coming your way, things like that. Then when I returned back to Egypt in 2019, WhatsApp had a totally different sort of like mode of action. Actually, it was used like instead of emails, instead of Facebook or parallel to Facebook, in addition to the instant messaging feature. So people would send files over over WhatsApp. Like I would maybe share the class notes with the student leader, and instead of emailing them or posting them on the learning management platform, although there was a learning management platform, and although all students and educators had an email. So this is why what I'm trying to say is that the tools of technology have maybe created for a particular purpose. How people adapt it to their needs and how they evolve with time is a totally different thing. I keep saying that people who developed WhatsApp or use WhatsApp anywhere in the world would be very much surprised how people in Egypt use WhatsApp. So instant messaging. Of course, instant messaging, as we'll see in the beyond the education and training, can also be used in a non-educational or training context. Then MOOCs, massive online open courseware. MOOCs, massive online open courseware. In the around like 2010 or something, this was the time that Coursera, whose screenshot is on the right, started sort of like filling the training space. This is not an education space, this is the training space. And at that time, people who used Coursera, like myself, were blessed because almost everything was free. You didn't even have to apply for a waiver. So it gave you this course. You can have access to the course, and you can have access to the learning resources, which are like videos, PowerPoint, course notes, and even attempt or do the exercises, whether they are assignments, whether they are MCQ questions. The only thing that you couldn't have if you had a free account was a certificate to say that you attended this or to get credits for it or something like this. At that time, there was a huge discussion about how MOOCs would replace traditional academia in like X years, because like you can see, for example, on the slide on the screenshot to the right, this is a course from Pennsylvania, University of Pennsylvania. And there was this discussion, okay, why would I as a student pay like thousands of dollars to go attend courses in Pennsylvania if I can attend them on Coursera free of charge, and the university would sort of like acknowledge these courses. And there was this discussion about how future certification would be based on what people actually know or can do, rather than the credentials from the universities or educational institutions. So a huge change over time. The screen on the left is from the FDI. The FDI has MOOCs. The WHO has MOOCs. Many organizations have MOOCs. Like during, for example, the pandemic, the COVID-19, the WHO had many MOOCs related to different things: how it is transmitted, how to manage infection controls, stuff like this. This particular MOOC from the FDI is about sustainability, which is one of the main focus areas of the FDI. On the right, yes, is this is a non-public health course from University of Pennsylvania about frontiers in dentistry. They talk about things like lasers and the explosion in the number of courses on MOOC platforms like Coursera, edX, and stuff like this is unbelievable. I mean, in 2010, definitely there was nothing related to dentistry or dental public health or anything dental. There were few public health courses because public health lends itself to the MOOC platform or MOOC modality. What's very special about the MOOC? So this MOOC we have been talking about. Well, MOOCs are like massive. Like one course can have an enrollment of thousands and thousands of students because you're enrolling from mostly home. If it is free of charge, like the FDI or WHO or the MOOC platforms in the early days, if it is free of charge, one would logically enroll and sort of like taste the course. If it is fine, you go on. If it is not, you just disappear. So this is massive and open because, like I said, in the early days, they were mostly open to anyone. You didn't have to be affiliated with this university to attend the course. And they are, of course, online, and there was this slogan, learn anywhere, anytime. And it is really true. The thing, however, about MOOCs is that they have a huge dropout rate because you wouldn't expect a course for which like 1,000 students enroll to go on with the same 1,000. This is one issue. The second is the not very much interaction. Like if I am offering a MOOC personally, I wouldn't be able, for sure, to interact with 1,000 or even 500 or maybe even 100 students in the course. So how does assessment get done? They heavily use the close-ended questions, MCQs, and if there are assignments, they ask learners to share. So, for example, I will read and sort of like rate or grade or evaluate the assignment of another person, and the other person will do the same for my assignment. And there are moderators on the platform who help guide things. Sometimes to increase interaction, there is a session, like weekly session or whatever the frequency, where there will be on synchronous or direct interaction between learners and instructors. This is another MOOC. This is from the Hong Kong Universities of Dentistry. And the screenshot actually captures one part. There are many other courses, and they have many things relevant to dental public health, like the minimally invasive, for example, minimal intervention dentistry for pediatric patients, fundamentals of cardiology, things which intersect with dental public health, I would say. So also, education and institutions, academic institutions like the Hong Kong University School of Dentistry are doing MOOCs. MOOCs, of course, depend heavily on instruction and design, and you need to have people who are experts in this, and they are costly to create. So they take time and they are quite an investment. However, like things in general, they have this overhead and you can keep using them for whatever time you like. Also, education, if we're talking about training and all these like shortcuts, we need also to talk about the learning management systems. The screenshot on the right is from the learning management system, the model of Alexandria University, Faculty of Dentistry, my school. And the screenshot that you see, it will offer all things like in the MOOC, okay? However, it is customizable, or it focuses, or it is only accessible by the students enrolled in this university or this class, actually, this course. This particular screenshot is one of the main strengths of the learning management systems like Moodle. Moodle is open source, so you do not have to pay like per student or per year or anything. You just need to have someone knowledgeable about setting the installation of the folder on a server and hosting, of course, with technical support. So the screenshot, like I say on the right, is one of the main strengths of the learning management systems, which what I would call managing big data, managing big data in education. These are the stats for one quiz or something, and it readily, just after the quiz ends, it gives you the stats automatically. So you know, for example, in the first half, how many how many students answered correctly, how many didn't answer or answered incorrectly, coefficient of internal consistency, which tells you whether the quiz that you developed is valid and reliable, and stuff like this. In the second half of the right screen, you can see actually stats for each question, like the main stats for any question, the difficulty or the facility index, like the Moodle calls it, and then the discrimination towards the end of the row. And these are very important if you're trying to create a question bank, like if you are considering having a nationwide examination to certify students in this, whether they are undergraduate moving to practice or people moving to specialty, and you're trying to create a nationwide exam for this. A question bank with standardized, validated questions are very important, and I do not think there is any way to do this without something like this, a robust learning management system that gives you stats on the questions and that you can use for assessing students in any, or learners in any setting. So learning management systems and big data. And then fast forward to 2024 with artificial intelligence, of course, in education, and we all know that students are already using them, like whether to develop assignments, to hopefully to train on things. And one useful thing that we can, one realistic thing that we can do in this context is acknowledge the presence of artificial intelligence, and that we need to train on them. We need to train our students and learners on them, and we need to know their like, I wouldn't say disadvantage, but what we need to look out for. They are very good for training, I would say, if you are short of educators, like most countries and most institutions are, because they can be trained on the correct thing, correct piece of knowledge, correct practice parts, things like that, and used repetitively by learners. They are there to stay, and they improve by the month or the week, I would say. So we need to acknowledge their presence and focus on the think about the ethical part of using AI in training, and the equity part of this, that it is available for everyone and in all settings and things like that. Okay, the second domain in the WHO manual, if you remember, was literacy. And I added before it communication. In most of the things which are going on about the use of technology to support oral health literacy, focus on communication, whether it is communication with targeted group or untargeted group. This paper is about the use of internet platforms for oral health information, and we know that patients who can use the internet will use it for health and for oral health in general. They will check about the symptoms that they have and what they need, the best course of action to take care of this. They will find dentists through the internet and things like that. This particular paper was about the use of internet for oral health among adolescents in Indonesia, and we also did this before this study. It was done also in Saudi Arabia, and the conclusions are they differ by country. In some settings, the platforms differ. Like I said, like internet platforms is like a general term, meaning it's things like Google and social media and websites of organizations and all these things. So mostly they are into social media, but not only. Sometimes they are dependent, or they look things up on Google. And this, of course, brings the issue of credibility of the information on the internet, and the responsibility that professionals have for communicating with lay people or with the general population. Many people would say that I do not have time to sort of like talk to people on the internet, but actually this is advocacy, and it is like a core public health skill, advocacy, and improving literacy of people. If they do not know about oral health from credible resources, they will the information that they find from any source that they can access. So this is another opportunity to remind us all that we have this obligation, I would say, of using the available tools that fit the context, fit the age group that we are trying to reach out to, including the internet in different things. Many of us have social media accounts, and sometimes we use them for academic purposes only, like posting that we have attended this conference. We have been granted this fund, sort of like this. However, if opportunities arise, and if you know that you have general population followers on your account, it would be good to use all the available opportunities to disseminate good information about things, especially if if there is a real opportunity, like if there is an incident, or if there is something which catches the attention of people, a common event, things like that. Internet addiction. I wouldn't say that people get addicted to the internet by looking for oral health information stuff. This is like a far stretch. However, if you are using the internet for to improve oral health literacy, like I just said, it is a good opportunity to remind the audience that you're reaching out to for general health purposes of different stuff. Like if I'm reaching out to adolescents, for example, I know that they may have maybe like tobacco problems, so I will drop a word or two about this, that they may be having a bit of a sedentary lifestyle, spending all time playing games on the internet. I would warn them about internet addiction, about the need to get physically active, to move, to watch their diets, things like that. So it is an art. Messages over social media and over the internet is an art, and it is actually a research field all by itself. There is very heavy research about the use of social media for behavior modification, or the use of technology in general for behavior modification. And this is one of them. Okay, this is the BRIGHT study. This was led by Zoe Marshman from the University of Sheffield. It's a very, I would say, very huge and important study. What they did basically was that, including a large number of middle school students from 12 to 15 years old, they designed a health promotion to change a health promotion program to change the behavior, mainly focusing on brushing. okay, using SMSs, short message services. And I remember this discussion with Zoe when she, at the time, we were also involved with another similar project that I will talk about in a minute. And I was listening to her concerns. At the beginning, they were, okay, we have this fund. Why don't we attempt to use the SMSs to change several behaviors that we know impact oral health? Like the primary target was brushing, and they were trying to get into the area of diet. And they discussed with people in the nutrition space and diet and stuff like this. And after several lengthy discussion, they arrived at the conclusion that it would be almost impossible to try to target more than one of these behaviors within the same intervention for the same group. Because when you think of it, when you're trying to change behavior like brushing frequency, suppose we target or we aim to convince these teenagers to brush twice daily, okay? This actually is different from brushing after each meal. So your messages about the frequency of brushing would be a bit different than they would be if you're targeting the timing of brushing. And again, then if you are targeting the technique of brushing. So there are many aspects to such a one behavior like toothbrushing that would need to be covered. You would not be sending one SMS. It is not like a one-time event, and it has to be repeated. The frequency of repeating the message is an important thing to look into. The timing of sending the message is another thing, and the content of the message, the tone of the message is another thing. So they said, okay, we can never do these things together. We'll just focus on oral hygiene and brushing. And then in the beginning, they thought that it would be like a one-way message. They would, for example, for a city or an administrative district, they would, from the school health services, they would obtain the mobile numbers of the students, of course, after the permission of the legal guardians and so on. And they will send these messages to tell them about the importance of brushing and that they need to do it and stuff like this. So initially planned for one way, and then they started receiving responses. So the students responded back that, like, I would send an automated, it has to be automated to you cannot possibly deal with this large scale or even a smaller, much smaller scale automation, sending of messages without automation. So the students would receive this automated message and they will respond back, and the servers pick this, and this put them in an obligation that they will have to respond. So the structure of the project had to be modified because they were on the other end receiving messages from the teenagers, and they cannot just ignore them. And what was more pressing was that some of the messages were really worrying. Like they would receive a message from a teenager that about suicidal ideation. So I sort of like, I don't like my life, I intend to do so and so and so. So they had to really like respond and also maybe identify, refer, notify, things like this. They receive messages about abuse, about suicidal ideation, about health conditions, other health conditions, things like that. So use of technology for behavior modification is a very hot area. This study is landmark. This is the protocol published in 2019. They have already finished the study. The conclusion that they arrived at is that the messages do not help much with behavior change. There were many lessons to learn, and there were things to address to improve for better impact. And they have also linked it with policymakers to include this in the regular NHS proceedings. So very interesting study. This is our study. We started after the BRIGHT study. It is not exactly along the same lines because what our focus was to use or to develop a multi-component intervention. Okay, so we have this problem of early childhood caries in Egypt, and we know this problem is really serious. We have known this for some time. So what we're trying to do in this study is reach out to the mothers of young children with, number one, motivational interviewing, which is face-to-face, first session. Then after 3 months, there is a reinforcement session over the phone. This is the first component. The second is messages. We call them oral health promotion message, or OHPM. We didn't send them through SMSs. We send them through WhatsApp, because number one, WhatsApp is very much used in Egypt. Number two, we thought it would reduce the cost of then paying for an SMS. The third component was videos. We call them storytelling videos. And in these videos, we had scenarios where an interviewer was talking to mothers of young children, and the mother would tell us about her experience with ECC and how the child suffered and what she would have done differently, and how she would advise mothers and stuff like this. So 3 components. So the technique which you see in the title of the paper, the multi-phase optimization strategy, this is a technique, engineering, originally an engineering-based technique, where if you, for example, imagine people trying to design a new car, and they say, well, we'll have this feature in the headlights, we'll have this feature in the seats, and this feature in the windshields, for example, and we would like to know which of them would be more attractive, would be best for the product. So this is the origin of the technique. It is heavily used also in behavior modification interventions, and we try to use it for the first time in dentistry, in oral health, to support oral health. Like I said, for mothers whose children have ECC problem. And there were 2 digital components, like I said, the messages sent through WhatsApp and the videos sent through also WhatsApp. What did we learn? Well, we thought at the beginning that the videos were very much worse than trouble. They took a very long time to develop. They were very, I would say, labor intensive. However, the conclusion of the study, which is almost now accepted, is that they didn't help at all with behavior modification. Okay, mothers didn't brush their children's teeth after watching the videos. Why is this? Because number one, we didn't send a video on WhatsApp. We sent a link to a video. Okay, and the pass from the link to the video to the actual watching of the video, we thought it was like short. However, it is clear that it wasn't, because sometimes they lost interest, sometimes they didn't have internet access, sometimes they didn't have enough internet package to spend on an educational video, things like that. And to start with, what we learned after talking with the mothers, because this is again the trial, what you see in this slide is the trial of, the protocol of the study. There were several publications after this in testing the acceptability of the interventions and talking with mothers. We learned that in the rural areas which we conducted the study in, the mobile phone is not for this person. Like, there would be a mobile phone in the family and everybody would use it. So, for example, when we sent the video in particular, sometimes it will be opened by another person, then the mother who we were targeting, like the grandmother, like the husband, like an older child, and then she would miss it and will not see. So videos which took a lot of time and financial resources actually, and we thought they were winners, they didn't do that much effect. The the WhatsApp messages or the oral health promotion messages were sort of like better than the videos, but they were not that wow. And we're not yet sure whether it was the content of the message, because we aligned the intervention with the COMB, with the capabilities, opportunities, and motivation framework. And in this study, the oral health promotion message was targeting motivation. So maybe we should have targeted something else, like we should have told them in the message that, okay, the problem that that prevents you from using or from brushing your child's teeth is because you do not have, for example, a toothpaste and toothbrush, and if you go to this place, you can get them free of charge or at a reduced price or something. So maybe it was an objective method mismatch. The study would yet have an economic evaluation because the use of oral health interventions to improve literacy is very important. However, they are very costly, and we need to be very sure that these interventions do not work, have the potential to work, or are like wows. Use of artificial intelligence applications in different dental fields, and this is again one of the studies or the type of studies that are being, I would say, like repeated very much. Like everybody is almost doing them at the present time. So you have assessment of AI in dental trauma, pediatric dentistry, in facial pain, and you name it. So what are people doing? They are using like the all like Chat GPT, like the different versions actually of Chat GPT, Google Bard, or all these AI applications to and testing whether they would provide valid answers to patients' questions. Okay. Several things to watch out here. Okay, to make sure that the questions and answers that researchers develop are valid. It is a lot easier to do this if you are talking about yes/no questions or multiple choice questions at most, because like you saw with the learning management system, you can generate stats for this. You can actually test the questions and whether they are valid, they have internal consistency, stuff like this. However, maybe we would agree that this is not the way that patients would ask a Chat GPT application for oral health, for example. If the patient knew that this is an option and she wants to verify if it is correct or not, this is like a very optimistic scenario. Most patients wouldn't even know whether, for example, in a dental trauma context, whether the right thing to do is a tooth that has been knocked out of her child's mouth. The right thing to do is to put it back in the socket, or to put it in a glass of water, or in saline, or hold it in tissue, stuff like this. She wouldn't know this. And if we expect like a mother to keep asking ChatGPT this and that to somehow get the knowledge to know the options and keep asking about each one in a yes/no context, this would be very time consuming for her, and I'm not sure others or users will do this. So this field of research is booming, and it has lots of potential because, like, for example, I am sure it will arrive at a stage when it would be, or hopefully it may be possible to say, okay, now we are assigning the health literacy intervention arm of this study or this program in the community to Chat GPT 4.0, for example. How would you do this? I would train the model, the AI model in Chat GPT on all the possible questions that I know people in the community would ask, and it will take care of this. You're supposing that the people in the community can have access to the internet, that they would know how to use Chat GPT, and that they would be convinced that they are getting the best service instead of having a dentist or a healthcare professional answer their questions. So things take time. Like 2 or 3 years ago, we wouldn't expect students to hand assignments developed by AI applications, but they do. So maybe in 2 years from now, we also would listen to a patient saying, no, I don't think your answer is like the up-to-date one, because I just asked ChatGPT before I came and it said that so and so should be done. So AI for health literacy. The third domain in the WHO framework is disease detection. Okay, this is teledentistry. Teledentistry boomed like telemedicine with the COVID, of course, with the pandemic. And some countries really did a great job using teledentistry during the pandemic. Like in this particular paper, we explored this, the situation of teledentistry and whether it is just at research stage or was actually practiced. And some countries had this virtual hospital or clinic where students would, patients or people who have an oral health complaint would log into the system, ask a dentist who remotely about this, saying, for example, I have this swelling, I have this pain, it has been going on for 3 days. What do I take? And the dentist would ask some probing questions and then, for example, prescribe medications or tell the patient that it is self-limiting and it will disappear in some days, or ask the patient to call a hotline to reserve an appointment because it has to be seen immediately. It is an emergency and it has to be taken care of. And these are few countries that did this all over the world, whether during the pandemic or afterwards. In most countries, there was like trials at a setting level, not at a national level, at a setting level. Like I would try it, for example, in Alexandria, people would try it in Delhi, things like this. And for one particular thing, by the time that whoever was trying was testing this lost interest, it would just disappear. However, it cannot be, teledentistry is there to stay, like most people believe, and many people, many countries, many organizations are taking steps to first ensure that the legal framework allows the use of teledentistry in this setting in the country, for example, that dentists would not be in trouble if they assess or communicate with the patient using teledentistry. Second, important thing which was raised by the study is how do I get paid? Okay, so if, for example, I do not get into trouble if I'm communicating with my patient using teledentistry, will I get paid? Will the reimbursement scheme in the country or the health insurance organization or whatever allow me to get paid even though I didn't physically meet the patient didn't register in the records of the clinic as paying a visit on this day. These were concerns that were raised by mostly high-income countries. In low and middle-income countries, in addition to this, there was the infrastructure, of course, the need for stable internet, for electricity, even in some cases, and for equipment. And now telemedicine, or how things started, was like basically you have a patient sitting, like it is a Zoom, okay? Like a patient would have a Zoom session with a healthcare professional, and they will describe the problem. And like I said, with some probing questions, the health professional will arrive at a conclusion and recommend an action. In dentistry, we have an additional thing to take care of that. In most cases, dentists need to see what's happening inside the oral cavity. And how do they do this? They do this mainly by things like an intraoral cameras, which are becoming very sophisticated, which are actually some cameras that we tested in a recent publication that we have published has better ability to detect diseases than the dentist or than a face-to-face examination. What's the problem with intraoral cameras? They are very expensive. They are sophisticated equipment that can do wonders, but they are very, very expensive. So alternative solutions need to be assessed, especially for low and middle income countries. What we are trying to assess in this study that you see here is can we use a smartphone camera instead of an intraoral camera to detect again early childhood caries in young children? Of course, there are many things to think of. Okay, like we used in this study. This is again the protocol of the study. However, the first part of it has just been published. The comparison of accuracy between the intraoral camera and the smartphone. We used actually the state of the art intraoral camera. It was huge. It was unbelievable. And we used an Android, the camera of an Android phone. It was good. I mean, both of them at different caries levels had an accuracy more than 90%, which is what most people would accept. So the preliminary results show that accuracy is good. We do not need to have the intraoral camera for disease detection. Of course, there are things that the smartphone would miss. But if the disease level is high, if you're in a rural area, like the trial was, if you're in a rural area where nobody goes to the dentist and where almost many people, like 60%, the level of ECC in Egypt is 60%. So 2 out of 3 children have the disease. The smartphone would be a reasonable alternative without the high cost of intraoral camera. We are still to see the impact on oral health outcomes of this modality. Then the last one is surveillance. Surveillance is the domain that has, I would say, the less interventions or less focus in the use of technology than the other 3 domains. This slide is about GIS, Geographic Information Systems, which has been around for like many years. It's a field of study all by itself. It is not like a feature that we are trying or testing for dentistry. People take masters in this. What it does is that it provides spatial data about disease, about access to care, about dentist distribution, many factors actually, about the best route to go from my home to the dentist, who seems to be the nearest one. But if you consider the direction of the street and the transportation modes, it is not really the nearest dentist. And the biggest by far demonstration of the abilities, sophistication, and beauty of GIS is the global burden of disease studies. The global burden of disease studies have been sort of like established by the Institute of Health Metrics and Evaluation in Washington, Seattle. This group began in 2000, stuff like this. So they are going to celebrate, I think, 25 years. And the publications are enormous. The citations are enormous. The impact is huge. Like in last November, the WHO had this surveillance workshop with the IHME, the Global Burden of Disease group, to sort of like use the data that the GBD group collects or develops to feed the portals and the decision making of the WHO, and this is huge. If you're aware of the 2022 Global Oral Health Status Report of the WHO, where every country has 2 pages describing the disease conditions, oral health conditions, and the determinants, the workforce issues, the policies, stuff like this. This is a huge thing that the WHO has done, the development of the report, and it is sort of like a baseline data that needs to be continuously updated. Where will the data come from? From the GBD platform group and studies, okay? And it has lots of data potential. This, for example, this is the global health data. I think they call it compare or something. And this particular screenshot, you can see This is not related to, this is the landing platform when you create an account and sign in, and you can see many things to the left panel, in the left panel that you can modify to get more stats. For example, you can, here is the caries. I selected caries, like you can see in this, the post, caries of deciduous teeth and of permanent teeth, okay? I want to see the number or the percent for the prevalence in at a global level and in India. And you have the stats here, okay? So this line is global, this is global, this is India, and this is all caries in deciduous teeth. Then the last 4 rows are for caries in permanent teeth, and these are the stats with confidence interval, because these are estimates generated from sophisticated regression models, taking into account that, for example, if a country does not have estimates, the estimates can be built using different factors. One of them is the estimate of the closest country, hence the GIS element. I believe that some countries have subnational estimates, and I think India is one of them. So it is a very useful platform to explore. They can also generate maps, and here is the tooth pain, a map of tooth pain due to deciduous caries in males. Of course, you can select males or females. This is the latest estimate, 2019, and what you see here is prevalence, the number of children with these conditions, and the estimates are as good as the data they are built on. So every time I use the GBT estimates or write about them, I keep saying that more studies need to be conducted to generate accurate estimates in the GBT studies. They also have this, the GBT compare, where you can compare different diseases. Here, for example, is an overall view of the dailies or the disability adjusted life years, how sort of like the amount of suffering or burden of the disease in this age group, which is young children less than 5 years old. And by far, as you can see, the red squares or rectangles are communicable diseases. The blue rectangles are non-communicable. The green, which are towards the bottom, are injuries and stuff like this. And they are also included in the latest estimates, the COVID impact. So lots of potential in this area. This is the another powerful platform to help you generate this. Okay, this is the DHIS2. The DHIS2 is an open source again platform that was created by the University of Oslo 20 years ago, and that it has been extensively used by people in different countries. I think there are more like than 70 plus low and middle income countries, and you can use it for per person, which is the tracker modality, or for events like, for example, focusing on a disease, including cares. Usually it is used for a communicable disease like Ebola. You have an Ebola event-based system in, for example, Uganda, Mpox, things like this. And it is it readily generates, like you can see this dashboard of stats to help decision makers apply interventions. This is a study from Alexandria University. We have used it. This is the building of the GHIS as an oral health surveillance system, again for preschool children, and it works beautifully. It is facility-based, of course, and we can use this in Egypt because of the many primary healthcare facilities spread of the Ministry of Health, spread all over the country. The last thing I would like to talk to you about is the Kobo Toolbox. Kobo Toolbox is it's a sort of like a questionnaire platform. Not only for questionnaires, you can use it to collect clinical data. Why is it nice? Why is it important? Because it allows you to use it in the field even if there is no access to the internet. So before going to the field, when we are sort of like gathering in the college, we open the form that we have previously prepared. We gain access, to it by over the internet. Then we go into the field. There is no access to the internet. We keep adding information for patient 1, patient 2, patient 3, patient 4, and so on. They are all in queue, and when we can sync back to the internet, things go to the database. It is beautiful. It is very versatile. Have lots of question forms. Almost anything you can think of. You can upload videos, images, text-based questions, MCQs, date, GIS coordinates. GPS coordinates. Many things. So it is really really handy and relevant to dental public health. I thank you very much for bearing with me for the very long, presentation. It was the longest. And thank you again.
Thank you so much, Maha. And it was indeed, it sailed us through the timeline of...
Harsha, I think you are on mute. Yes?
Okay. Just 1 second. So thank you so much, Maha. And you indeed sailed us through the timeline of technology and its marriage with dental public health. So yeah, thank you. And we came to know about new things like the last few ones, DHIS2, Kobo Toolbox, and I'm sure all the others have also benefited from this. And over to Dr. Bharathi, Associate Professor in Dental Public Health in our CDR AIIMS, and she'll take up the next questionnaire.
Thank you, Professor Maha. Am I audible? Yeah. Thank you so much, Professor Maha. This is a wonderful session we had today. We, in fact, came to know a lot of things about the technology, how it developed over the years, and how the research has evolved through years, utilizing this dentist technology in its patient care, also in research. So I invite the audience. First of all, I thank all the audience for actually participating and listening to the entire session here. So I request the audience to actually participate in our question answer sessions. They can put up their questions through the chat box. So we have some questions. I will just see them. Any questions from the audience?
You can unmute also and ask.
Yeah, kindly unmute yourself. Can ask the questions. You can give inputs also. Your experiences can be shared here. So the session is entirely for the audience, so that we have a fruitful discussion with the audience also.
Actually, we are taking their lunch time maybe, so everybody is. It's more than one here, so we'll just wait for another minute, and if not, then we'll.
In the meantime, I have a small question. So yes, it is definitely that we have benefited a lot through this technology, but how far we take this to the common man? So that's where the glitch is, especially the children. When it comes to preventive technology, though we have developed a lot of apps, what we mentioned, the MOOC and other things, a lot of things have been come up. But when it comes to the students in the rural background, particularly, so how can we help it out? So can we have something like QR codes in the textbooks? So we have actually that for develop for the other information system. So our own children here, they have it. But the same thing, maybe we can plan to implement some QR codes about the preventive techniques of oral health care through the textbooks.
So there's one hand raised.
Yes. Okay.
Yeah, there's a question, I think, here from the audience.
Ask them to unmute and ask.
Can you kindly unmute, Dr. Umesh? Dr. Umesh? Yeah.
Yeah, madam. Am I audible?
Yes, yes.
We want to see your face also.
Am I audible, ma'am?
Yes, you are audible. You're audible, Dr. Umesh.
Yeah. I have a question. Uh, Using the technology, how far you can justify the response what we get from the participants? Because most of the surveys what madam has projected, few are using through SMS and telemedicine and all. Technology, correct, at the present era, it is reachable everywhere, but how the participants do understand the questions or the suggestions, whatever it has been texted. Because whenever we do any questionnaire survey, we usually go for validation and all those things. On what basis these questions were being prepared and how it has been educated and how the confirmation has been taken, whether the answers what they have given is justified.
Okay.
Yes, important points actually. I would like to get back to the point raised by Doctor about reaching the children and the QR codes and things like this. This is very important. I think actually both comments or questions are related. They are about the equity and the digital divide, okay? Because like digital technology is available, whether it is available to everybody equally. Everybody means like the division between urban, rural, between rich and poor, between young and old. This is one of the things that we need to be addressing, actively addressing, because it cannot be assumed that the technology can only benefit those who have access to it, whether because of age or because of money or because of the place where they live. Many interventions are available, just like Dr. said, like having QR codes leading to the oral health promotion messages or text or whatever on children's school books. The issue of how the questions are developed and how they relate to the population we target or the intervention in general. It is also very important. Now, there are several aspects to keep in mind, okay? In some cases, because technology is readily available and sort of like people are keen, let me say, to use it, what may be done is that, okay, we're now sitting together at lunch and we try to sort of like develop this new research point, and someone suggests, why don't we do this? And then the other one, yes, we can ask them about that. And then the third said, yes, I heard that these questions can be used. And then by the end of lunch, we have like 10 or 12 questions that are collected all over the table. And then people put it together. And then someone who is maybe like a bit tech savvy uses Google form, which is readily again available. And then you have a questionnaire which is ready to be disseminated to people. It has not been tested. It has not been validated. It has not we have not obtained the feedback of the target group for it. So my point is that because technology is readily available, sometimes it facilitates or it enables people to do things that they should not be really doing. And the rigorous approach to whether it is the development of intervention or the development of programs, if we're talking about public health practice, or the development of tools for research, if we're talking about research or anything, the same rigorous structures that should be applied regardless of the tool that we are using is also important. Now there is a point that about literacy, okay? If you are targeting people who cannot read, then it will be very difficult to use text-based anything, whether programs, interventions, anything. And I would like to here also emphasize the huge advances in AI, okay? There is text to voice, okay? So for example, if we are If we have developed a series of oral health promotion message and tested them and verified them and validated them in text, then there must be other tools that
One
can
second.
help
Okay.
translate these oral health and that can help translate these messages to text for people who cannot see text, if they are visually impaired, for people who cannot read because they are illiterate or because they are too young. So the technology will also help with this.
I'll take one question. There's another question. Is there any standard validation tool of questionnaire available for text messages specific to oral health?
This is a very important question. The manual that I refer to, the WHO manual, actually has at its end, like appendix or something, a series of oral health promotion messages for different age groups for different oral health topics. It's like a library. This is very useful. However, we didn't use this because there wasn't actually anything targeting oral hygiene or brushing for preschool children. So we had to develop our own, and it is just like a regular validation exercise. You begin with face validity among experts, saying that yes, this oral health promotion message, this one message, for example, is that or targets the motivation according to the COMBI model, and it fits the mothers, things like that. Then you invite a group of mothers and you ask them, is the language understandable? Is it easy to use? Do you know what I mean? Things like this. So the validation techniques apply. There are validated messages, like I said, in the WHO manual, but maybe you are in a position where you would like to develop your own messages or tools or whatever.
Yeah. And our participants are also suggesting that language translation and cross-culture adaptation also needs to be done.
It is very important. Like I said, you will end up in most cases doing your own exercise, whether it is just for translation, and even if it is, for example, sometimes we find tools in Arabic, like people talking in Egypt, but it is not like the same dialect that the people would use. So it will need cultural adaptation, because otherwise people will feel that these things are not like addressing them. They are not really talking to me, and it will create a barrier and there will be non-response.
Yeah.
So yes.
Another question, Maha, it's what are the ethical challenges of using the AI chatbots or generative AI models, especially in context to oral health education?
Yeah. Yes, most of the existing AI models are not are trained on data from the global north. Let me say, okay. So mostly they will have no problem with generating content in English for people living in the northern hemisphere. That's Europe, Australia, and North America. However, this will not be in any way useful to our purpose. For example, if you're using a chatbot for adult Indians, you need it to be in their language. If I'm using it for mothers of young children, I need it to be in my language. So the ethical issue of what data the chat bots or AI models in general is trained on is very important. And this brings us to equity, because if all the models are trained on the global north data, then this is unequitable. We cannot by definition use them. We'll need to create our own tools, and the learning curve, the infrastructure, the physical resources for this are something to think about. So yes, there are quite some, most people concerned about AI in general are concerned about the ethical part and the equity and justice of its use.
Yeah, exactly. So thank you. And no, there's no question.
Yeah, I have a small query. How do we determine the sample when we are distributing this Google Forms? Especially, we want to do a small study among a group of group of professionals. So, how do we communicate to them, and how do we spread this Google Forms, matlab, in the sense ki how to determine the sample size.
Okay. So I think the question is about the sample size for a small questionnaire and how does it reach the participants. The sample size determination techniques are on one side, okay, they have the rules like by experience that you will get always a smaller or you require a smaller sample size if you're doing a comparison between groups than if you're trying to develop a point estimate, like the prevalence, for example, of caries in preschool children. Point estimates, cross-sectional studies end up with far larger sample sizes than comparison studies, which like case control, cohort, or clinical trials. So this is one thing. The issue of disseminating the link to the electronic questionnaires is a very important thing. You get responses from people you reach out to. So, for example, in one study it was about the COVID vaccination in Egypt, okay? And one of the research assistants was assigned to disseminate the survey link because she said she had quite a network and stuff like this. Now, okay, how many responses did you get? I got like 1,200, and this was very good, okay? And then I started analyzing the data, and I had a real problem in framing the sample because most of the responses were from people who were students in biomedical fields. This was her network. So when she disseminated the link to the questionnaire on, for example, like her Facebook page, or to send it to people she knows and ask them to forward the link, she only got responses from people who are similar to her. So I had to sort of like keep doing wonders to try to describe the sample because it is in no way representative of the Egyptian population, where there is a high literacy rate, and not all people would be students in the biomedical field. So the dissemination is very important. Ideally, all studies would be to be representative. They need a statistical or a random sample. You need to pick from a framework. However, by definition, electronic questionnaires cannot do that unless you are targeting a closed circuit. So, for example, let's say you're targeting or you want to assess the opinion of dental academics or academics in India about the use of AI. I assume that you have a list of these academics with their emails, and then you can pick randomly from them. To do this for the general population would be extremely difficult unless you have a database again of people. Like, for example, if I want to do something in the NHS, this is actually doable because almost all people in the UK are registered with the NHS, and if one of the background information the NHS collects is their emails or their phone numbers, I can reach out to them and send them the link to the electronic questionnaire. So sampling is very important, very, very important. Thank you for the question.
Thank you so much.
Okay. So, there are no more questions, Maha. So we will close this session. And we had approximately a full house. Now people are, of course, leaving. So 100 on Zoom. Around 150 had joined from the YouTube link. So it did help, and it had a vast coverage. So thank you all the participants, and hope to see you next month with some other lecture series. Thank you, Maha, once again. Bye-bye.
Thank you for having me.
Bye.
It was a pleasure. Thank you very much. Bye. Bye-bye. Bye.